Today's presentation is about hypothyroidism. Previously, I have uploaded a presentation on hyperthyroidism. So, in that management of hyperthyroidism, I have mentioned that the patient who was having hyperthyroidism due to Graves' disease, she will be managed by antithyroid medication. But if thyroid functions are not controlled by antithyroid medication, and if there's a decision to do the thyroidectomy in that patient, it can be done in the second trimester. So whenever the patient of hyperthyroidism, Graves' disease, has undergone the uh, hypothyroidectomy, then patient is not having thyroxine. Then obviously thyroid has been removed. So this patient now need thyroxine for the rest of her life. So when we discuss hypothyroidism, we will discuss the patient taking thyroxine because we need to monitor the dose of thyroxine because patient we were giving it to the patient. Patient is not generating any thyroxine for herself. So those patient will be also discussed in hypothyroidism. But there are different causes of hypothyroidism like iodine deficiencies, the leading cause in the whole world for the hypothyroidism. But the leading cause of hypothyroidism in the modern developed world is Hashimoto's thyroiditis. So whenever they give the question, what is the leading cause of hypothyroidism in the whole world, that is iodine deficiency. And if they say that in the developed world, then it's Hashimoto's thyroiditis. So there are causes of hypothyroidism other than Graves' disease, treated Graves' disease. But why I am discussing here for the treated Graves' disease? Because in the management of Graves' disease, we have discussed that those patients have thyroid stimulating immunoglobulin, which stimulate thyroid receptors. And because under the effect of those thyroid stimulating immunoglobulins, thyroid become hyperactive and produce excessive thyroxine. Now we have removed thyroid, but thyroid stimulating immunoglobulins are still there. So we have mentioned in the hyperthyroidism that these antibodies cross the placenta and stimulate the fetus thyroid hormone, thyroid gland as well. So if the patient is a treated case of hyperthyroidism, Graves' disease, then now she is taking thyroxine. We will manage the thyroxine according to the rest of the hypothyroid patient. But at the same time, we will check those patients at 20 weeks for the antibody titer for uh, thyroid stimulating immunoglobulin because they are there in the patient and they will cross the placenta and they will stimulate the patient thyroid hormone, thyroid gland, and they will cause again those symptoms like IUGR, fetal goiter, and tachycardia, um, oligohydramnios. So if thyroid stimulating immunoglobulins are present at 20 weeks, then we will do the serial scan and the serial in the fetal-maternal unit. And in the scan, we want to see all these things. If fetal tachycardia is more than 170 and other features of IUGR, then we will monitor that patient and manage accordingly in the fetal-maternal unit. So here, I will discuss hypothyroidism, I will discuss the management of hypothyroidism, and along with that, I will again discuss this in a separate point. I will emphasize on that point that those patients who are treated case of Graves' disease, we will check thyroid stimulating immunoglobulin in that patient as well. The thyroid iodine deficiency we know is leading cause and in the whole world, but in the developed world, there's a Hashimoto's thyroiditis. It is also autoimmune disease, and it has antibodies like thyroid peroxidase receptor and antibodies. So these antibodies are different from hyperthyroidism. So we will discuss all this in this presentation. So now I will regarding hypothyroidism. Hypothyroidism is common and found in almost 1% of pregnant women. Hypothyroidism is common in infertile couples. So in the talk article, they have specially mentioned the portion where they have discussed that when there is infertility, subfertility in the patient, when their thyroid function were tested, they were having subclinical hypothyroidism. I will discuss that again in some other presentation. But here I will only focus on the hypothyroidism in the pregnancy. It is common along with other autoimmune disease like type 1 diabetes, pernicious anemia, for in the cases where it is autoimmune like Hashimoto's thyroiditis. Worldwide, the commonest cause of hypothyroidism is iodine deficiency, but it is rarely seen in the developed world where the autoimmune Hashimoto's thyroiditis is common. So when we see that patient is having one autoimmune disease, we check for other autoimmune disease as well. So along with Hashimoto's thyroiditis, patient may have type 1 diabetes and pernicious anemia as well. So this is the physiology of thyroid. We know this, that the hypothalamus produce thyroid receptor, thyroid releasing hormone, and then which act on the pituitary, and pituitary produces thyroid stimulating hormone, and that act on thyroid gland and produces T4, T3. So when these T3, T4 is also converted in T3 in the peripheral tissue. So when we do the, there's like goes a negative feedback on the pituitary gland and hypothyroid due to T3, T4 and T3. And if there is TSH is less, then obviously there is a positive feedback. If the TSH is increased, there's an increase of TSH because of maybe thyroid. In this case, thyroid is not working. So pituitary will release more TSH to act on the thyroid to release more T4, T3. So in these patients, their T3, T4 levels are below the normal range and TSH will be increased. So a dietary iodine is essential for thyroid hormone synthesis. Thyroid, physiology of thyroid disease is common in women of childbearing age. The circulating thyroid hormone are thyroxine T4 and triiodothyronine T3, of which only the free portion are active. So there's a total thyroid hormone level, most of that bound to the immunoglobulins and albumin, but only small portion of thyroxine is in the free form, and free form is the hormone which is active. So in the pregnancy, there is increased immunoglobulin production. So more thyroxine is attached to immunoglobulin. Total thyroxine is increased, but free thyroxine will be on the same level. So we will assess the activity in the patient not by total thyroxine level, but instead we will use free thyroxine level. So biologically more important, T3, free T3 is formed mainly peripherally in the liver, kidney, and muscle, where it is converted from T4 by deiodinase enzyme. Most tissues, including heart, brain, and muscle, have specific nuclear receptor for free T3, by which metabolic and cellular activities can be influenced. So hypothyroidism is more dangerous for the baby because in the first trimester, fetal thyroid starting to produce thyroxine from the 5th week of the pregnancy, but it start producing small amount because thyroxine is very important for the fetal brain development. Thyroxine, when thyroxine fetus produces at the 5-week, small amount, and fetus is dependent on the maternal thyroxine level in the first trimester. So after the first trimester, fetus produce its own thyroxine, and it is not dependent on mother's thyroxine level. So it gives us a point that if maternal thyroxine level is mother is hypothyroid in the first trimester, is not having adequate thyroxine replacement, then damage has been done to the baby because there is no adequate brain development in the baby because fetus was only dependent on the mother thyroxine in the first trimester. After first trimester, baby can produce its own, but now the brain damage has been occurred. So it's very important to manage the dose of thyroxine in the first trimester. And also, it is obviously there are some undiagnosed case of hypothyroidism. And when they become pregnant, and in the pregnancy, when we in the booking visit, we then notice that the patient is having hypothyroidism. So that is not good for the baby because due to due to lack of thyroxine supply to the baby, there is not optimum brain development in the baby. So risk factors for thyroid function are history of thyroid dysfunction, thyroid surgery, family history of thyroid disease, goiter, positive thyroid autoantibodies, clinical symptoms and signs of hypothyroidism, diabetes type 1, history of miscarriage, preterm delivery, other autoimmune disorders, history of subfertility, history of therapeutic head or neck irradiation, age equal to or more than 30 years, previous treatment with amiodarone. Amiodarone causes hypo and hyper both. Previous treatment with lithium. Recent exposure to iodinated radiological contrast agent. So we in the pregnancy, we should use the pregnancy specific ranges of thyroxine level. Why? Because in the pregnancy, there's some specific changes which alters the level of thyroxine in the maternal blood. So what are the changes? Because half-life of thyroxine binding globulin. Thyroxine binding globulin half-life extends from 15 minutes to 3 days. Its concentration triples by 20 weeks of gestation as a result of estrogen-driven glycosylation. Total thyroid hormone levels increase. This is what I have already explained. And free T4 and T3 are test of choice in pregnancy. They should be interpreted in relation to pregnancy-specific reference ranges. So these are the levels. In the first trimester, the reference range is 0.1 to 2.5. And in the second, 0.2 to 3. And in the third, 0.3 to 3. So what are the pregnancy-specific changes which make us to check the patient thyroxine level and want to compare it with the pregnancy specific values, like increased GFR, glomerular filtration, and great uptake of iodine into the thyroid gland, because obviously now maternal thyroid gland is producing thyroxine for both mother and baby, and this increased uptake of iodine. So if the patient is already iodine deficient, this thing will worsen. So into the thyroid gland, deplete iodine and cause or worsen iodine deficiency. When there is severe maternal iodine deficiency, maternal iodine trapping overrides fetal needs, resulting in cretinism. Concentration of deiodinase 3 increases in placenta with gestation, releasing iodine where it is required for transport to the fetus and possibly contributing to reduced thyroxine transfer. So more thyroxine is produced from the mother and the baby. So there is a reduced level is more consumption of thyroxine. And also there is thyroxine binding globulin half-life is increased. So trimester specific ranges should be used to interpret thyroid function during pregnancy. Optimal management of hypothyroidism should be achieved prior to conception. So very important thing in the pre-conception care that we want to make patient euthyroid before conception. Pregnant women may need to alter their dose of thyroxine in early pregnancy. So when patient come in pre-conception clinic, we will discuss all those points which I have mentioned in the previous presentations, like for the maternal medicine. Like we will ask the patient about the general health and check her labs to see how her condition is, at what level condition is now. If condition is controlled, then it's good time to conceive. If condition is not well controlled, then patient should continue contraception, and unless the optimal health is again restored. And then we will tell the patient to take folic acid. We will tell the patient what it means to get pregnant with this condition, and how this pregnancy will affect condition, and how condition will affect pregnancy. And we will tell the patient about the antenatal care specific to that condition in general, and then we will so that patient is prepared what to do. And we will tell patient that whenever she becomes pregnant, we will write to her GP that do the when she becomes pregnant, the GP will do the thyroid function test and increase the dose of thyroxine. So because we know that in the first trimester, if thyroxine level is not adequate, and it will end up in the brain impairment of the child. So optimal management of hypothyroidism should be achieved prior to conception. Pregnant women may need to alter their dose of thyroxine in early pregnancy. Treatment for hyperthyroidism can often be reduced in third trimester. So as I have mentioned, this is for the Hashimoto's thyroiditis or autoimmune area, because I have mentioned in the previous presentation that in the autoimmune conditions, it becomes better in the second and third trimester, and sometimes Patient does not require any medication. Like for hyperthyroidism, I have mentioned that patient may not need anti-thyroid medication in the second and third, it becomes so better. But the autoimmune condition worsen, and they have flare up in the postpartum period. So this is, again, they're saying treatment for hypothyroidism can often be reduced in third trimester to minimize the risk of fetal hyperthyroidism and then restored postnatally. In the fetus, pituitary thyroid axis is controlled in a very similar way with iodine supplied transplacentally. Prior to 12-week gestation, maternal thyroxine, but not free FT3, free T3 crosses the placenta. Maternal thyroxine crosses the placenta prior to 12 weeks. Following binding to receptors in fetal brain cells, and thyroxine is converted intracellularly to free T3, a process thought to be important for normal fetal brain development. From 12 weeks onwards, placental changes prevent significant passage of maternal thyroxine, and fetal thyroid function is controlled independently of the mother, provided that her iodine intake is adequate. So what hypothyroidism generally causes in the mother and the baby, we will discuss it. Hypothyroidism causes tiredness, constipation, weight gain, hair thinning. Thyroid function tests show elevated TSH and low T4. Hashimoto's thyroiditis is the commonest cause in the developed countries and is characterized by glandular destruction by autoantibodies, particularly antithyroid peroxidase antibodies. So what are the causes, general causes of hypothyroidism? If there is a primary hypothyroidism, there's a problem in the thyroid, and there can be reason that problem is in the pituitary, and in the secondary hypothyroidism, and tertiary where problem is in the hypothalamus. So primary hypothyroidism, autoimmune disease, due to autoimmune disease, atrophic thyroiditis, Hashimoto's thyroiditis, and iatrogenic can be radioiodine therapy, thyroidectomy, antithyroid drugs, transient due to subacute thyroiditis, and postpartum thyroiditis. And the other iodine deficiency is the leading cause in the whole world. Secondary hypothyroidism due to pituitary failure, pituitary tumor, and tertiary, there is hypothalamic failure. So complication of hypothyroidism in pregnancy. In the mother, there is anemia, postpartum hemorrhage, cardiac dysfunction, preeclampsia, and placental abruption. So we will see all these things, and we will manage, do our antenatal management to prevent all these complications. In the fetus, baby have prematurity and low birth weight, congenital malformations, perinatal death, stillbirth, neurodevelopmental delay, and congenital hypothyroidism is autoimmune. Hypothyroidism in pregnancy. Maternal thyroxine concentration do not have a major impact on fetal thyroid function beyond the first trimester. Factors that could influence thyroxine dosage during pregnancy must be considered. Reduced absorption in the first trimester related to nausea and vomiting. Because of nausea and vomiting, there is a reduced absorption of iodine, and so we will, and thyroxine will also be washed out. So we may need to change the thyroxine dose. Malabsorption resulting from binding of thyroxine to newly commenced iron and calcium supplements. Suboptimal control prior to conception. So this is the most important thing. So that's why we need to optimize the patient's health before the pregnancy, because in the pregnancy, there's also a lot of things going on. So we want to control the things which we can control before the pregnancy. So altered compliance with, it is another issue that patient sometime they become improved, the symptoms become improved in the second and third trimester, they stop taking medication, or the patient thinks that maybe she is affecting the safety of the fetus, she stopped taking medication. So these are the factors which result in apparent need to increase the dosage. So normal variation, what are the normal variation in the thyroxine dosage? These will be adjusted according to specific patient need, but normally, what are the range of the normal variation in the thyroxine dosage? The therapeutic window of thyroxine is broad, with dose adjustment usually 25 or 50 microgram, that is by approximately 25%. So we might need to increase the dose up to from 25 to 50 microgram, but dose should not be increased without checking thyroid functions. That's why when patient become pregnant, we will, in the preconception clinic, we will tell the patient that we will write back to your GP to check your thyroid functions when your pregnancy test is positive, and increase the dose of thyroxine accordingly. Although in pregnancy, increased concentration of thyroxine binding protein occur that result in increased total thyroid hormone pool. As we have mentioned, that there's more stored bound thyroxine level. So this will also help whenever there's a need for thyroxine, where thyroxine can be released from those pools. This may help to explain why thyroxine increases are not routinely required despite the physiological changes. So these are changes, but sometimes we don't need to increase the dose because there is already enough pool inside the mother. So, uh, so that's why we need to check the thyroid function first, and then we will increase the dose. So in the preconception care, these I have mentioned major points, so I will discuss it again. Adequate level of maternal T4 are essential for normal fetal brain development, particularly in the first trimester, because T4 will attach to the fetal brain cells and convert it to T3. So that's why we need the adequate level of maternal T4 in the first trimester. Check TFT's thyroid function test to ensure thyroxine dose is adequate. Aim to achieve a TSH level of not higher than 2.5 milliunit per liter. Inform patient about fetal-maternal risk factors related to hypothyroidism, and emphasize on importance of compliance to treatment. So in any maternal condition, compliance emphasis is very important. In 25% of cases, there is need to increase medication in pregnancy. Advised to contact GP to check TFTs, free T4 and TSH as soon as the pregnancy test is positive, as the dose of thyroxine 25 to 50 microgram may need to be increased if TSH is more than 2.5. Advise folic acid 400 microgram because there is no need to give extra folic acid like 5 mg. So we will advise the routine folic acid and review contraception. If TSH is not controlled, then we will ask the patient to continue the contraception unless the optimum health is achieved. In the antenatal care at booking, check TFTs and take history of thyroid disease. If the patient has history of any of the following, check thyroid receptor antibodies. So these are the point where I mentioned that if patient is ever associated with the Graves' disease, then we want to see that these thyroid receptor antibodies are present or not. So we need to do the serial growth scan for these patients. So we will check the thyroid receptor antibodies in patient who have history of hyperthyroidism, thyrotoxicosis, or Graves' disease, total or partial thyroidectomy, and radioactive iodine treatment. So we want to know what was the cause, and we will explore these, and then we will do the thyroid receptor antibodies. Patient without the above history should normally be managed in the general obstetric clinic. If there is a new diagnosis of hypothyroidism in pregnancy, so patient is not previously diagnosed and there is no adequate thyroxine control before the pregnancy. Now she has become pregnant. First time you know this, she is having hypothyroidism. It means that she is not having adequate stores of thyroxine in her blood. So in the first trimester, it's very important to have the optimum thyroxine in the mother so that fetus brain development will not be affected. So thyroxine treatment should be initiated urgently at 1 to 2 microgram per kg per day. Then TFT is repeated in 6 weeks. Thyroid peroxidase antibodies should also be checked. TFTs should be checked once every month, every trimester, and 4 to 6 weeks after any change in the dose of thyroxine. Thyroxine should be titrated to maintain serum TSH concentration not more than 25 throughout 2.5 throughout all trimester of pregnancy. This I have already mentioned. Thyroxine should not be routinely increased in pregnancy without checking TFTs first, as there is some evidence that excessive thyroxine could be harmful. There is no need for regular growth scan unless there is another clinical indication, like if there is, if patient is at treated case of Graves' disease and there is thyroid receptor antibodies are present. If patient has history of Graves' disease, treated Meyer thyroid antibodies at 24 to 28 weeks. If antibodies present, then do serial scan, growth scan to see baby's growth, heart rate, and goiter. So it's in the hypothyroidism is 24 to 28. In the hyperthyroidism, we check at the booking. And if at the booking it's negative, we will check at 24 to 28 weeks. If at booking it's positive, then we will again check at 20 to 22 weeks. So intrapartum care and the postnatal care. No alteration to normal care required in labor. Following delivery, the patient should be advised to resume her pre-pregnancy dose of thyroxine as long as hypothyroidism as well as was well controlled prior to pregnancy. So TFT should be checked 6 to 8 weeks postpartum with GP. Now, neonatal care, most of these patients will not have thyroid stimulating immunoglobulin and routinely checked, because most of the patients are not every patient is treated case of Graves' disease. So should be treated as TSI negative. That is normal postnatal care with no additional testing for neonate. Like we know the most common cause of hypothyroidism is Hashimoto's and iodine in the whole world. If patient have a positive TSI, neonatal care should be as per hyperthyroidism guidance. Breastfeeding is safe. Heel prick test is done on the 5th day of life to rule out congenital hypothyroidism along with other conditions. So in now regarding iodine deficiency, because in the Hashimoto's there's antibodies and a lot of things, but in the iodine deficiency, we only need to replace iodine. We don't have to give thyroxine or anything, because there's iodine deficiency. When we give it to the patient, thyroid is already working, and it will use iodine to produce enough hormones. So worldwide, neurological cretinism is the leading preventable cause of mental handicap. It affects 2 to 10% of people in iodine deficient areas and causes mild mental handicap in further 10 to 50%. Pregnant women usually have low or very low T4 and normal T3 with raised TSH levels and a compensatory goiter. The developing cochlea, cerebral neocortex, and basal ganglia are more sensitive to iodine deficiency, especially in the second trimester, resulting in deaf mutism, intellectual deficiency, and spastic motor disorders. So these things are, if there's iodine deficiency, these all things will, the baby's hearing will also be affected, and deaf mutism, obviously, then baby's not hearing and baby will be mute because of that. Less severe maternal iodine deprivation spares hearing, speech, and motor function, but causes mental handicap. So less severe have mental handicap, and if it's more severe than the second trimester, or other things are also will also be damaged. So iodine administration prior to conception or up to second trimester can protect the fetal brain, and when given early enough, reduce miscarriage and later pregnancy loss. Sufficient iodine intake, 150 microgram per day during pregnancy and lactation, is necessary to meet the need for increased thyroid hormone production and provide iodine to the fetus and the neonate. So do not give excessive iodine to prevent hyperthyroidism. So normally this amount of iodine is generally present in the pregnancy vitamins. So whenever patient is having other supplements for the pregnancy, we should check that she is having that supplement also includes the iodine in that as well. Thank you so much.